Great. Well, good afternoon, everybody. Hopefully those slides are showing up okay. I'm excited to be with you today to speak about COVID-19 and provide an update on facts related to the coronavirus pandemic in Tennessee, as well as talk about a hot topic around masking and share some of the scientific evidence and data that's out there, and then, of course, have plenty of time to answer any questions that you all might have. So to start with, I just want to share sort of the high-level overview of where we sit in Tennessee. These are data as of 2 p.m. yesterday. And I will go ahead and say that I will share these slides with the team so that they can be disseminated to all of you. There are links throughout that reference where on our website you can access these different data points. I know there's a lot of information on the website and out there on different sites, and so hopefully this will help clarify the best places to find some of these data points. So as of yesterday, we are approaching 125,000 cases of COVID-19 in Tennessee and close to 1,300 deaths. This is the main landing page of our COVID-19 website in the health department, and so there are a couple places that you can click. And I'm going to talk a little bit more about that, but a lot of the additional data is found here under this link for complete data report, including county level information. So really since probably, early April, we've been tracking metrics related to COVID in the state on a daily basis in these three big buckets. And these initially were born out of the White House reopening gating criteria. Obviously now we're reopened, but I do still think that they are helpful buckets to really track our data trends. And I'm going to talk more about these in depth, but the first bucket is symptoms. So looking at not necessarily people that have been diagnosed with COVID by testing, but people coming to emergency departments with diseases that could be consistent with COVID. Of course, looking at case rates themselves and trends in different parts of the state. And then lastly, and perhaps most importantly, is looking at morbidity and mortality from COVID-19, particularly related to hospital capacity and hospitalizations and then deaths. So I do just want to share before I dive into that specific data that we have developed a new critical indicators report that's on the website. It's updated weekly on Fridays. And it actually has a lot of the data points that I'm going to share today in there that are updated every week. And so, I think it's really helpful for people to know what's happening in their communities and what's happening statewide. And so hopefully this report is helpful. It also has fairly extensive technical notes as to where the different data sources are that we generate these visualizations from, if you want to recreate them at the county level, at the regional level, with a lot of the data that we have publicly available. So as I already alluded to, the first bucket of data that we are tracking is related to syndromes, and this is through a surveillance system called syndromic surveillance, aptly named. We actually collect emergency department data from close to 100 hospitals in Tennessee. This is de-identified data that's received generally within 24 hours of a patient encounter, and we get information on their chief complaint as well as their discharge diagnoses. So there are two specific syndromes that we have been tracking during the pandemic. The first is influenza-like illness, recognizing that COVID is in many ways similar to influenza with its clinical presentation in many people. And then a separate definition is for COVID-like illness, or CLI. And so both of those lines are on this graph here dating back to last fall of 2019. So the pink line is the influenza-like illness and the blue line is the COVID-like illness. And you can see that we really had a peak of the COVID-like illness in mid-March. We had a resurgence again, really mirroring our increasing case counts in late June, early July that has started to decline again, and ILI has remained very low. So this again is non-specific in many ways, but it is thought to be slightly more timely than some of our standard reporting. And so the hope is that this can give kind of a red flag at the state level or in certain communities that we could see an increase in cases in the coming days or weeks. So the second bucket, of course, is just our trends of the number of cases every day. So this is by specimen collection date or by illness onset date for cases that didn't have a test conducted. And you can see what I think everyone is familiar with, that sort of initial peak of cases in late April, and then really a resurgence here in mid to late June, that we are starting to see some evidence of stabilization from. I would say we're certainly not continuing to have case counts increase to the degree that we were in early to late July. But as I'll speak about in a couple of minutes, we're also seeing actually some decreased testing volume. So it's difficult to know exactly if the stabilization or decline in new cases is due to a true decline or it's due to fewer people seeking testing. So this is a little bit easier to digest. This is the number of cases reported by week. And again, we see a similar trend with that sort of potential plateau or stabilization here over the last week, but in conjunction with that, a decreasing number of tests in that same time frame. So for reference, here in week 31 was our highest reported week to date, and we had just over 17,000 cases reported. In contrast, some other states that are more populous have had days where they've had 15,000 cases reported in a day. However, this is still a tremendous burden of disease and a great, effort and undertaking for our health departments, to manage case investigations for every single one of these cases over such a short time frame. So this metric looks at the number of active cases. The idea is that obviously people that were diagnosed with COVID back in April are not currently any risk to the community, and so we try to capture people that have been diagnosed more recently and therefore, perhaps better represent the degree of ongoing community transmission or risk in a community. And so we have been hovering right around the 40,000 mark of active cases statewide for the last couple of weeks, again with a dip here in the last week or so. So this metric is calculated based on several different things, either if local public health investigators go back into the patient record in our surveillance system and indicate that the person is recovered and has finished their isolation period, or after 21 days they fall off of that tracking completely. And obviously we exclude folks that are deceased from the illness. So this graph is the 7-day average of new tests, so the number of tests conducted daily or reported daily, dating back to early April. We've now conducted over 1.7 million tests in Tennessee. I think we continue to really be a leader nationally in testing, especially given our population size, and really pretty persistently have been in the top 10 of per capita testing across the country. This is a real push by Governor Lee early on to ensure access to testing, and all of our 89 rural health departments continue to offer testing to anyone regardless of symptoms, which I think is not the case in many states around the country. So we saw a big increase in the volume of testing in early July. I think probably that was multifactorial due to rising rates of disease in the community and more awareness of the need to be tested. We also instituted a requirement for weekly testing of staff in nursing homes starting July 1st, and there are about 30 or 40,000 staff in nursing homes, so that's a big volume of people seeking testing. And so we went from averaging 8,000 to 10,000 tests a day to 20,000 to 30,000 tests a day, and have been sitting right around that 20,000 to 25,000 in the last week or so. Although we have had days as low as 12,000 or 13,000 tests in the last week. The other metric that we're watching very closely is the percent of tests that are positive. So I think, this is important to interpret in the context of the prior slide. Obviously, if we're doing less testing, we might see that our percent positive goes up. Conversely, if we are doing more testing, we might see that our percent positive, or we hope that we would see our percent positive go down. We actually haven't seen that throughout much of July, and I think that's largely because there was more disease transmission in the community. Our cumulative percent positive is shown here in that salmon color, and it's now sitting right at about 8.4% of all tests. And our daily percent positive oscillates quite a bit, and has been as high as over 13% in the last couple of weeks, more recently hovering between 9 and 11% on any given day. So I mentioned, aside from just tracking the number of cases, we of course think it's really important to look at the outcomes of this disease, and so tracking mortality and morbidity very closely. So this is a graph looking at the total number of deaths from COVID since the pandemic began. As I said, we now have close to 1,300 deaths reported. And this is by date of death. So there's a lot of artifact in death reporting. It can take some time. There can be a lag before deaths are reported to us. I do think there are a lot of myths and confusion about how deaths are classified as COVID related. And we have an active part of our sort of incident command structure is our Office of the State Chief Medical Examiner. She and her team, Dr. Adele Lewis, are very involved and personally review death certificates for every death reported from COVID in Tennessee. They sometimes, if there's concern that this is not a true COVID-associated death, they'll speak with the treating clinicians. They will request medical records. And so it's not just having died and having a recent positive test. It's having died of an illness that was likely either due to or impacted by a COVID-19 diagnosis. So, for example, if someone dies in a car accident, but happened to have been diagnosed with COVID the week prior, we would not count that as a COVID-associated death. If someone is in the hospital with pneumonia and then gets COVID on top of that and dies of respiratory failure or multi-system organ failure, then that would be a COVID-associated death. Or someone that was healthy and developed COVID and in a poor clinical course after that, that obviously would be a COVID-associated death. So again, I do think there's a lot of confusion here. But I do want to reassure that this is something we watch very closely. I have no reason to doubt that any of these deaths that we've identified as COVID associated are such. In large part, we've been fortunate in Tennessee that our case fatality rate has actually been much lower than in many other states. And because those volumes have been lower, our team has still been able to be involved in every death investigation. I think when you look at some other states that have had such high numbers of deaths, they don't have the ability to do that extra level of analysis and in-depth looking at death certificates and, as I said, medical records or other things as needed. So our case fatality rate has hovered right around 1%. We have seen an increase in deaths in the last couple of months in conjunction with our rising case counts. Previously, we were averaging 6 or 7 deaths reported per day. Now it's close to 11 deaths a day. But still, that overall percent remains quite low. And I really think that was because of the big push for testing early on and our ability to test people that don't have symptoms. We see that half to 2/3 of people tested in our health department clinics are not symptomatic. Now, obviously, some of those folks still go on to test positive. The data suggests that about 20% of COVID cases probably will never develop symptoms. And so I think the fact that we're capturing more of those asymptomatic or very mildly ill folks in Tennessee than probably some other states are has largely contributed to why this rate is so low. So the last piece is obviously healthcare system capacity. This has been a huge focus since this all began in March with a substantial concern that the impact of a novel pathogen in a naive population could be just the complete overwhelming of our hospital system capacity. So fortunately in Tennessee, we have had a long-standing tracking system for hospital capacity called the Healthcare Resource Tracking System, or HERTS. It's been around since 2006, and acute care hospitals across the state reported to HERTS daily or weekly, even before COVID happened. So we pretty quickly ramped up that capacity to include all of the metrics that the federal government is now requiring reporting on, some of which are listed here: bed utilization, ventilator utilization, PPE availability, the number of current patients admitted, among many other metrics, which hospitals report into every day. So these data are available on our website. This is the breakdown of current hospitalized patients in the state, with the total number in the top in black, the number of ICU patients in red, and the number of ventilated patients in blue. And really, for the last couple of weeks, we've seen that our COVID patients have been holding pretty steady at about 11% of all hospitalized patients in Tennessee. And then some of those other metrics, hospital floor bed availability, excuse me, ICU bed availability, ventilators, isolation rooms are also shown. And again, this is all at the statewide level. So for the last couple of minutes, I just want to touch on effective primary prevention measures. I mean, this is really the mainstay of disease control for this virus, and we cannot overemphasize how important each and every one of these metrics are. By themselves, none of them are a silver bullet, but taken together, they can be incredibly effective at slowing the spread of COVID in a community and decreasing the amount of disease transmission that we see. So none of these are novel, especially for people in healthcare, but I will reinforce them anyway. Avoiding large groups and gatherings, especially in confined spaces, is incredibly important. We have seen a myriad of clusters of disease related to, birthday parties or attending church services and sitting closely together, or other sort of close-knit large group settings, unfortunately, are really just prime for disease transmission. Anytime we are around others, trying to maintain that minimum of 6 feet of distance. Now, there's nothing magic that happens at 6 feet, and so the further apart you can be, the better. But certainly, this is not a virus that spreads as effectively through longer distances in the air as some others, and so whatever physical distance you can put between yourself and other people is hugely helpful. Staying home when sick, I cannot emphasize this enough. So many clusters in nursing homes or other settings that we've seen have started when people have come to work not feeling well. And I recognize that for some people that's easier than for others. We have to work for a paycheck, and unfortunately sick leave policies are not uniform across the state or country. But I implore folks, especially right now, that, and especially if you work in a high-risk setting, to please not come to work while sick, even if it's just a mild cough or feeling a little bit off. That's, again, part of why we offer testing at our health departments for anyone. You don't have to meet certain criteria. We really want to know and allow folks the ability to be tested if needed. Washing your hands and using alcohol-based hand rub frequently. Fomite transmission does not seem to be the predominant form of transmission for COVID, but it is certainly possible and probably part of the picture. So to the degree that we can just keep our hands as clean as possible, that will be really impactful. And then along the same lines, cleaning and disinfecting high-touch surfaces and objects like our cell phones. After you go to the grocery store and have touched all the things there and then have your phone in your hand, wipe your phone down. It's hard to know what you've come in contact with and could have transmitted to those objects. And then lastly, which I'll talk about a little bit more over the next couple of slides, is wearing a face covering. I think there has been a lot of confusion around face coverings during the pandemic. Unfortunately, the messaging early on was that they're not effective or even harmful. I think there was a great deal of concern in March and April about the supply of PPE in this country, and so decisions were made to make recommendations that would hopefully spare the use of PPE for healthcare workers that really needed them. But unfortunately, the ramifications of that messaging is that there has then been a lot of confusion around masks and how helpful or not they may be. But I do think that there is a growing body of evidence around that. And I will just, before I get to that in more detail, reiterate again that, staying away from large groups and maintaining social distance is so important, but there are also some areas that are really high risk, and that's in particular crowded places with close contact and that are confined and enclosed with poor ventilation. So there's been some fairly notable outbreaks in bars or restaurants or, again, other sort of tight, close-knit settings where there's not a lot of airflow. To the degree possible, we really have to emphasize to people to try to stay out of those situations as much as they can. So I do think there are some many good studies. There's also some very powerful evidence from this pandemic about these prevention measures, especially facial covering use, and I want to share just a couple of those. Because I continue to hear frequently when I'm out and about in the state that, there's no evidence for masks, and that's just not true. So this was a public health investigation aboard the USS Theodore Roosevelt in April of this year. They had over 1,000 cases on the ship, and CDC did a follow-up survey of service members, about 400 of them, and found that those who wore face coverings, those that avoided common areas, and those that observed social distancing were statistically less likely to be infected with SARS-CoV-2 than those that didn't take part in those measures. Similarly, this investigation got a lot of attention back in May. There were a couple of hairstylists in Missouri that worked, unfortunately, for about a week each with respiratory symptoms, who both ultimately tested positive for COVID-19. They cared for 139 clients during that time while they were working. But fortunately, the city had a mask ordinance, and both the stylists and their clients followed that ordinance. And so public health did contact tracing and 2 weeks of follow-up of all of those clients and didn't find any cases of COVID-19 among the 139 exposed clients or their secondary contacts. And, in a salon that's typically not a huge space, often working in very close contact with other people, I think, again, very reassuring about the potential impact of facial coverings. And then this study is really just meant to be representative of many others that are out there. This is a systematic review of over 170 observational studies from 16 countries, looking not just at COVID-19, but several other coronaviruses, SARS and MERS. And basically they found that physical distancing and face masks were associated with a lower risk of infection when you look at the data from all of those studies pulled together. Again, I don't think this is shocking to many of us, especially those of us in healthcare, but I do think it's important, to note, given the narrative that there's not any evidence to support mask use. And then I want to share a recent Vanderbilt analysis that I think is really powerful. They looked at the time intervals of mask ordinance initiation in Tennessee, and so as of August 4th, we now have about 60% of Tennessee residents that live in counties where there is a mask ordinance. This breaks that down by healthcare coalition. And I'll walk you through, these names are a little bit funny, but the Highland Rim is the Nashville area and sort of surrounding counties. Mid-South is the Memphis area and surrounding counties. Southeast Hamilton is the counties around Chattanooga. Northeast is the northeast part of the state. Knox East is the Knoxville and the counties surrounding Knoxville. Watch 7 is much of West Tennessee, so Madison County, Jackson there, and surrounding counties. Upper Cumberland is the plateau, sort of, between Nashville and Knoxville in the northern part of the state, and then South Central is really the area below sort of Nashville and that South Central area of the state. And you can see in this slide I originally pulled together for a presentation in that Watch 7 jurisdiction, but you can see there's a great amount of variability there. So we see, that in some parts of in sort of the Memphis and Nashville areas, nearly 100% of the population is covered by mask ordinance, all the way down to the South Central area where there are no counties that have a mask ordinance. But what I think is the most powerful is that they then looked at hospitalization growth rates by patient zip code. So, we know that hospitals pull from areas far beyond their actual county or zip code. And I think this is even more notable and powerful in the rural areas of the state where we might have, one hospital serving 3, 4, 5 or more counties. And we see that when you extrapolate out, if patients coming to those hospitals come from zip codes where there is a mask ordinance on the far right versus counties where there's not a mask ordinance on the far left, we see a pretty substantial impact on the hospitalization growth rate. So for those hospitals serving patients from areas where there's not a mask ordinance, we have seen hospitalizations increase 200% throughout the course of the last couple of months. In contrast, for hospitals serving patients where more than 3/4 are coming from zip codes with mask ordinances, we see that really things have been very stable and, if anything, sort of leveled off in the last couple of weeks. So again, it's not masks by themselves, it's masks plus all of these other primary prevention messages. But I think these data points are really powerful in showing the impact of those actions on controlling the spread of disease in our communities. And then lastly, I'll just mention, as hopefully many of you have seen, the governor's team recently released a new PSA campaign at the end of July, the tagline being "Face It, Masks Fight COVID," really tried to pull in key stakeholders and a diverse representation of people in this video. There is a PSA toolkit available online for free, and they've really encouraged community partners to utilize that messaging in their own social media, postings in their clinic, whatever it may be, just to try to get awareness out about masks. So looks like we're right at noon, so I wanted to leave plenty of time for questions. I think that is the data that I had to present, but I'm hopeful there will be questions, and happy to answer any that you have related to anything I showed, or any other information that would be helpful.
Great. Well, thank you for that. The last slides and graphs were new to me, and that is very interesting just to see the difference in zip codes and who is doing what. So just a reminder to the people that have joined us that you can put a question in the chat box, and I'm happy to ask Dr. Phil about it. But in the meantime, I have a few that I just thought I'd dig into you with. So the first, let's just keep it very broad. What's the biggest myth or misconception? If there's one thing you would like to really clear up or that you hear most often, what would that be?
Oh man, I mean, I think a lot of it I addressed with the mask issue. I think one that I hear more frequently than I would like, and I think is maybe one of the most damaging, is that this whole thing is a myth, that COVID is made up, and that's not the case. I mean, I can say with certainty that the almost 1,300 people that have lost family members to COVID know painfully well that this is a real disease that can have a devastating impact on families. And again, we're very fortunate in Tennessee that that number is as low as it is. I think anytime we have a new disease and we're learning so much in real time, there is the potential for misconceptions, and data and information is going to evolve and change, and that's to be expected. But I think to suggest that this disease is not real or is not as potentially impactful as it is unfortunate and is misguided, because it only unfortunately leads to propagation of behaviors that are going to allow for more disease transmission and put more people at risk. And I would also say, we have a lot to learn about this disease. There's no doubt that a lot of people have mild illness or, may have no illness, and that is certainly notable. But there is also a growing body of awareness of people, even young and healthy people, that have been infected, that have developed almost a post-COVID like syndrome, where they experience extreme fatigue and debilitation almost for weeks or months after their illness. It's not anything necessarily life-threatening, but it's greatly impactful to their quality of life and their ability to be a functioning member of society. There's also growing concern around, cardiac sequelae in COVID patients. Again, a lot of this is all very small numbers and almost anecdotal, but I think, I would caution people from being too confident with a disease that's brand new in this world, that we have to take time to learn about in anything certain. And I think it's hard for us in science and medicine. We often don't like to say anything with certainty, and I think in some ways that's probably harmed us a bit in some of the messaging throughout this entire pandemic, because I'm reluctant to say anything with certainty because there's still so much to learn. But I would just caution folks, when you hear those myths of complete denial around the virus, that there are plenty of people that have either been infected or lost loved ones who I think would speak to the contrary.
Yeah. And I think in a lot of ways, part of the reason we are where we are right now is because in the beginning, especially in the beginning, we didn't know it as much as even we know now. And so, there were a lot of information given before we had the facts, right? And that's to keep up with the news cycles and, right, everybody wants to be the first to break the story or have everybody's attention. And a lot of misinformation did get out. But I think it is important for all of us in public health just to remind people, and we're still learning, right? And whatever information we have, we've got some new information, but we're still learning, and to constantly remind people of that. So what do you say to people who just say, this is a bad flu, or it's not as bad as the flu, we're overreacting because it's, again, the flu, right? Everybody likes to make that comparison.
Yeah, I think, I mean, so the mortality rate is or fatality rate is definitely higher than the flu. So, I mean, we typically see for seasonal influenza that the case fatality rate is 0.025% or less. And we do a pretty good job with influenza surveillance. We certainly don't capture every case, but even in our past pandemics or bad flu seasons, we don't see the fatality rate quite where it is for COVID-19. And I think the other thing that's really important to keep in mind about flu and comparing this to flu is that with flu, we have some degree of population immunity, right? Most of us have had the flu at least once. We have a vaccine that many of us take every year. Now, flu can shift, and that's why we can still get the flu and why the vaccine isn't 100% perfect. But that prior infection and vaccine exposure, often provides, probably more protection in the community and for individuals than we might realize. And for this disease, we have zero population immunity. No one has ever seen this disease before. Our immune systems have no prior recognition of it or ability to fight it off more aggressively because of that, and we don't yet have a vaccine. And so I don't have the numbers in front of me, but for people that like to do math, if you just do some simple calculations of, if you assume that we don't do anything and we just let this disease, uh, you know, transmit throughout the community unhindered, and that 60% of people that are exposed will get infected, which is a totally made up number, and I don't think we really understand the attack rate quite yet. That and the fatality rate, say, is 0.5%. We're still talking about potentially millions of deaths in the United States, and hundreds of thousands of deaths in Tennessee, and that's really impactful. And again, thinking and talking critically about, a lot of our efforts have been to ensure that we can maintain healthcare system capacity. Our hospitals get pretty strained during a bad flu season, and again, we have all of those other factors in our favor in terms of immunity and risk of severe disease that we don't have for this disease. And so, I think when you do a little math and look at the potential burden, it's very different from flu, and I think it's really hard to make that comparison because of how long flu has been present in the world and our communities, and how many of us have some degree of immunity that helps prevent us from having those severe outcomes.
Right. I do think that's probably the most important distinction, is right. So, and not only are they different and we've got the immunity, there's also the vaccine variable and that, which we just do not have at this time. We do have a question in the chat box asking if gaiters, and I don't know what that is. I'm assuming a shield.
I think it's the neck covering that comes up over your face.
Okay. So are gaiters, and then maybe also face shields, are they a good substitution for masks?
Yeah, so there was actually a paper that just came out in the last week or so that compared, I think, like 8 or 10 different types of masks. It was not a perfect study, as few are, but it did shed a little bit of light and raise a little bit of concern around gaiters in particular, partly because of the fabric that many of them are made out of, and talked particularly about things made of fleece type material, that the holes in that material might be large enough to allow more respiratory droplet transmission than we typically see with other mask types. It did also show, not surprisingly, that surgical mask type masks probably are slightly more effective. The more layers you have in a mask, the more effective they are. Certainly don't recommend masks that have an exhaust valve, because then you're just putting all that out into the community. It, theoretically might be protective to you, but it's not giving any of that sort of community benefit by preventing you from potentially spreading infectious droplets yourself as you breathe and talk and laugh. So, I think, as with anything, if you're stuck in a crazy situation and left a mask at home, but you have a gaiter, then definitely use it. I certainly wouldn't say not to use it. Certainly better than nothing. But I do think we're going to learn more about the sort of stratification of masks and which are best in the coming weeks and months, and not surprisingly see that medical grade type things are better, as they should be, with a stratification sort of down to things that might not be quite as effective. And then your comment about face shields. So, face shields, I think, really are only helpful in protecting the mucous membranes of our eyes. They're not meant to replace masks, because they with all of the opening below, they still can allow for droplet transmission out and in. And so, I think there has been a growing recognition of the potential for mucous membrane contamination through eyes and nose if your nose isn't covered with a mask, leading to the CDC to update their guidance for healthcare workers that they wear eye protection at all times. And so we really recommend, for people certainly in healthcare, either goggles or a face shield plus a mask. And then for people in the community that want to be ultra cautious, that face shield is really just meant to protect your eyes from that potential contamination, which, sounds silly, but I will say, this is not related to COVID, but I have a dear family member that works in healthcare that wears glasses even, but had a patient cough in their face and got droplets in their eye and ended up getting a rip-roaring infection of CMV from this patient. So it is very real, and we sort of poo-poo it sometimes, but I think it, especially for people in healthcare, it's worth that extra layer of protection.
Right. And the important thing too for the gaiters also, and we're still learning, right? So I'm sure there will be so much more information as we go. So another question too, I think there's a lot of confusion about when we should get tested. So you said in your presentation that anybody can go to a health department, which I don't think I knew, or if I knew, I forgot. But still, just knowing that there's a shortage, if I don't think I personally would go unless I really thought I was sick. And so what is the guidance around that some more?
Yeah, first and foremost, testing should be for people that are sick. I think, however, my caveat to that is that there is a growing body of evidence of the sort of vast clinical spectrum that we can see with COVID, and it's not always fever and cough. And so I think we have to get outside of that box of, well, I don't have fever and cough, so it can't be COVID. Especially in younger children, especially in people with atypical immune systems. We're seeing some people present just with nausea, vomiting. Certainly in osmia, loss of taste and smell has been an increasingly recognized symptom. People that have, bad headache or just terrible fatigue. And so, I think I would really encourage people that just have, that feel ill or unwell, even if you don't have classic COVID symptoms, especially if you work in healthcare and have potential exposures or have concerns about exposures, that, there shouldn't be any huge reluctance to get tested. I don't recommend that everybody and their brother just go out and get tested once a week because they're curious. You're absolutely right. We don't have the testing capacity to support that. It's also not really that helpful. I do think there's sometimes an opportunity for testing people that are asymptomatic if, I know some folks who have been tested or sought testing because they wanted to go visit an elderly family member in another state, and they wanted to make sure they weren't one of the 20% that were negative. were asymptomatic and positive. So if you're going to be in a high risk setting where maybe you are not going to be able to socially distance as aggressively, or you're going to be around someone that's higher risk for complications for a period of time, I do think it can be helpful. Still knowing though that that test is just that one point in time, and if you're not taking appropriate precautions in the time period from when you were tested until when you take that trip or have that exposure, if you're not being very cautious, you could be exposed and turn positive during that time and still be infected. So, it is a very small window that a test result gives us insight into, because it's just that day that you were tested. But I do think there is space for asymptomatic testing in those sort of situations that can be helpful. But you're absolutely right. Testing first and foremost should be reserved for people that feel unwell, have symptoms, so that we can act accordingly.
Right, great. Well, I've got two more questions, unless we get an extra one in the chat box. So the first is just there's in looking at Tennessee Department of Health's Facebook page, sometimes there's some interesting responses sometimes to comments. And I think there's some people that think that masks could somehow be harmful. So I wanted to address that. And then also, because a lot of our members are affiliated with school systems somehow and are preparing to go back to school, I'm just curious what your thoughts are on spread with children and protection with children.
Sure. Yeah, so your first point, I don't look at the Facebook page too often because I can't. There's a lot of comments. I do think there are some myths around masks being harmful. There's been some pretty now viral videos done by physicians or others that have worn an N95 with a surgical mask, with a face shield, and gone out and run 5 miles, or worn it for their 24-hour shift with a pulse ox on the whole time, and shown that it's really not impacting your ability to oxygenate. We all know that healthcare workers wear masks constantly during their shifts, and don't have adverse health outcomes from that. So I think I would also caution, and I certainly want to acknowledge that there are people in whom masking may be uncomfortable. Especially if I have underlying lung disease and I baseline feel a little bit short of breath, putting something over my face probably doesn't make me feel like I'm moving air very well, and can help it perhaps exacerbate that feeling of dyspnea or shortness of breath. Heck, myself, when I walk up the stairs in a mask, sometimes I feel, just because of that lack of feeling air movement, you can feel a little bit short of breath. But I think it's important to reiterate that feeling short of breath does not mean that you're not getting enough oxygen. Those things are not the same. And so, especially for people that have underlying lung disease, we know that COVID can be devastating if you're infected. And so, to the degree that those people can tolerate a mask, I think they should try to protect themselves, because a mask, and I say this not to be, crass or unkind, but a mask is certainly more comfortable than the ventilator is, and we do not want to see those people end up in the ICU or critically ill. And if a mask can help protect them from that, they can adapt to it and walk a little slower and take some more breaks so they don't feel short of breath, then I really think that they should do it. I do think it is important also to note that if people are wearing cloth masks, that they really need to wash them daily. If they're getting damp or contaminated, I don't think it's overtly harmful, but we also don't want people to be breathing infectious particles into a mask and then wearing that same mask for weeks at a time. So keeping them clean is also a really important part of the process to make them effective. And then to your second question about schooling, gosh, there's so much attention on going back to school, and I have a 20-month-old, and I'm quite frankly glad that he's not in school, because I recognize the stresses on all sides. There are undoubtedly benefits to children being in school, especially in many of our rural areas where there might not be as much access to meals or community support or other, just critical developmental opportunities for children. But we definitely want to do it in a safe way. And so we know that, the risk of transmission in schools is definitely linked to the amount of transmission in communities. And so this is where communities can really band together and help protect their schools and their teachers by practicing all of those prevention measures that we've talked about to drive down the number of cases in their community. I also think there's been tremendous collaboration between the Department of Health and Education at the state level and at the local levels around the state to develop plans for how to respond to cases in schools, to ensure that there's communication between those groups and transparency. There are going to be cases in schools. I don't think anyone will suggest otherwise, but to the degree that schools can implement those primary prevention measures as much as possible, it will certainly decrease the risk to those students. And conversely from those students to their families. And then as long as we can have a clear plan in place as to how to respond, I think, it's going to take some time to all figure it out together, but I'm optimistic that we